Welcome to Diagnexia Case 4. The clinical history in this case is that of a 20-year-old male who presented with intractable diarrhea accompanied by a loss of weight. He had lost about 10 kilograms over a 3-month period, and this loss of weight coincided with the onset of diarrhea. He complained of 10 to 12 loose stools per day. There was no blood in the stool, and it consisted mainly of mucus and watery fluid. After routine blood investigations, he underwent upper GI endoscopy, which was reported as normal, although mild flattening within the duodenum was commented on. Random biopsies were taken of the esophagus, stomach, and duodenum. I'm going to share the duodenal biopsies with you, and the low magnification images showed relatively normal architecture with a little bit of villus blunting and shortening focally, mild increase in chronic inflammation in the lamina propria, but otherwise the surface mucosa was intact. There was no increase in intraepithelial lymphocytes and no evidence of atrophy. However, on closer examination of the mucosa, the presence of spores within the surface epithelium were clearly noted. Indeed, several of these spores were in vacuoles with clearing within them and showed 2 spores, and in this particular case 4 spores present. In other areas, these vacuoles contained multiple spores, and variations in the morphology were also apparent, with some of them showing almost a division-like feature of the spore within the vacuole. The vacuoles tended to be infranuclear, and the nucleus of the epithelial cell was displaced more luminally. This is a pus stain which highlights the vacuole containing these elongated sausage or banana-shaped organisms with their nuclear detail highlighted by pus positivity. Again, note that the vacuole containing these organisms have displaced the nucleus towards the lumen and occupy the bulk of the cytoplasm of the cell. The diagnosis is Cystoisosporiasis. What are these organisms? Well, they're protozoans belonging to the coccidiosis group of protozoan organisms. The family is the Sarcocystidae, along with Sarcocystis and Toxoplasmosis, which also belong to this particular family. They are obligate intracellular diarrhea-inducing pathogens, and the species that infect humans are Cystoisospora hominis, Belli, and natalensis. Interestingly, the organism was first described by Rudolf Virchow in 1860 and was named Isospora in the 1930s. The organism then underwent a nomenclatural change and was renamed Cystoisospora in 2006. The normal locale of these organisms are tropical and subtropical. However, that being said, with the ease of travel to exotic or previously exotic destinations, the infection is not restricted to tropical and subtropical areas. And people who return from these locations and present with diarrhea, one should always bear these exotic organisms in mind as well. How are humans infected? It's the fecal-oral route, and ingestion of contaminated food and water is the mode of acquisition of this infection. Human-to-human transmission is exceedingly rare, if at all does occur. The clinical features, both immunocompetent and immunocompromised individuals can be affected. Infection, as I mentioned previously, is acquired orally, And most infections follow a benign self-limiting course in the immunocompetent patient, with recovery in days to a few weeks at worst. The organism parasitizes the duodenum and jejunum preferably, and causes fever, diarrhea, crampy abdominal pain, and ultimately ends up with malabsorption and weight loss accompanied by peripheral blood eosinophilia. In the immunocompromised host, of course, infections tend to be a bit more protracted, and they have recurrent infections as well. With regards to pathology, the organism has a predilection for the duodenum and jejunum. However, infection of the colon, the mesentery, liver, gallbladder, and indeed spleen have also been described. The endoscopic appearances vary from normal to flattening of the mucosa, depending on the severity of the disease. And of course, the microscopic appearance will also reflect the severity, with the more severe cases exhibiting blunting and atrophy of villi. There tends to be an accompanying increase in inflammation within the lamina propria, including eosinophils, neutrophils, and as a compensatory feature, cryptosome hyperplasia is present in response to the blunting and atrophy of villi. In terms of the diagnostic features of the organism, several stages of the parasite can be seen, and these go from sporozoites to schizonts to merozoites and indeed gametocytes. So depending on the stage of development in the life cycle of the organism, and I'll try and demonstrate this in the next slide, you will see a variation in the shape and indeed size of the parasite. The merozoites present the characteristic elongated banana-shaped forms in the epithelium that I demonstrated on the pus stain. And when organisms are scanty and one has a high index of suspicion of an infective process, these organisms stain with the pus, as I demonstrated, as well as the Zeal-Nielsen stain. And this is a schematic representation of the life cycle of Cystoisospora. And if we pick it up at the mature or sporulated oocyte stage, these are ingested by the human, and once enters the gastrointestinal tract, the oocyte or mature sporocyte excists and ruptures, releasing several sporozoites into the gut lumen. These sporozoites home in on duodenal and jejunal mucosa, penetrate the individual cells, and enter into the cytoplasm, where they have a vacuole surrounding them and are discrete from the remainder of the cytoplasm. Within the cell, they then undergo the asexual cycle of the life cycle of Cystoisospora. The next stage from a sporozoite is a trophozoite, which is somewhat more amorphous and irregular in shape, and then these develop into schizonts, which are discrete, rounded, spore-like organisms, which can be single or multiple within the vacuole. The next phase of development from a schizont is into a merozoite, and these merozoites are very reminiscent of sporozoites, but are in the asexual cycle of the life cycle and have the ability to spread into adjacent epithelial cells and increasing the amount of infection that the host has. After a few weeks of these asexual cycles, in which the merozoite is now spread within the intestinal cells, at this stage the merozoites then develop into the sexual phase of the life cycle, and the merozoites divide and form a microgamete, which is the male gamete, and a macrogamete, which is the female, and then the sexual magic happens between these two gametes to produce a non-sporulated oocyte. And the non-sporulated oocyte is predominantly excreted in the feces into the environment, and a minimal proportion of them actually mature within the gut and perpetuate the cycle by then developing into mature sporulated oocytes, or a sporocyst. However, it is required that environmental factors and temperature, etc., that are required in general for non-sporulated oocytes to actually mature and form the sporocyst. Treatment is with antibiotics, and double-strength trimethoprim and sulfamethoxazole is the treatment of choice. If the patients are allergic to the above antibiotics, then pyrimethamine is recommended. Ciprofloxacin is also used in some of the cases, but these tend to be less effective than trimethoprim and sulfamethoxazole. So the take-home points from this particular case is that these very characteristic spores of Cystoisospora can be seen within the jejunal or duodenal mucosa and can present as rounded or elongated or indeed banana-shaped organisms. They tend to be underneath the nucleus of the epithelial cell, where they throw a vacuole around themselves, thus delineating the spores from the remainder of the cytoplasm, making identification under the microscope somewhat easier. And sometimes the sporozoites may be aligned in a T-shape, which is quite characteristic. And the important thing to remember is always think of infections in patients who present with diarrhea, and I'm sure we've all seen cases of putative inflammatory bowel disease, which indeed have turned out to be amoebiasis or other infections.